One of the things that differs is in relation to the amount of inflammatory cells. The other is how big this lipid core is compared to one which is stable. And the third is how thick is this overlying muscle layer compared to one that doesn't rupture. So there are three characteristics that we know about. You can measure inflammation systemically in blood using a particular biomarker called C-reactive protein. And what has been shown is that as the level of C-reactive protein increases, then your risk of myocardial infarction also increases. And this was shown irrespective of whether somebody was on aspirin or not. Aspirin is an anti-inflammatory. And you can see it's still there, that association is still there, but it's attenuated to a major degree. Did that improve the marker, the ability to predict? Well, a little bit. So when that was added to the Framingham, you can see that there was a slight increase in terms of assessing how good that test was. That doesn't mean to say that inflammation isn't important. It might simply mean that that marker isn't a particularly good one, or the fact that you're trying to look at a local inflammatory process by measuring something in the blood, and for that reason it doesn't work. Where does inflammation come from? It comes from infective agents. So within the plaque, and it's been demonstrated, I'll show you in a minute that there are microorganisms within plaque. Now, the question is whether they're etiological or in any way involved or just innocent bystanders. There is trauma in terms of treating coronary disease. We use angioplasty, which is passing a balloon into the artery and expanding it. There's bypass surgery, where the coronary artery affected is bypassed. There are free radicals, toxins